All right, welcome everyone to this Thursday, 1st of April. We are excited you are with us today for our Foundations of Global Health series. Alexa, next slide. Very good, okay. Global health is a varied and exciting field to which many healthcare providers, researchers, and faculty aspire to being professionally engaged. With our being a globally connected world and with COVID-19 uniting the world to solve an issue, global health has never been more relevant. This year-long programming is designed to feature our experts in the field of global health, KUMC's faculty, researchers, and clinicians, our international partners, and our community partners. Each presenter will share his or her personal journey, educational background, mentors, books, and articles that gave inspiration, challenges, lessons learned, successes, epiphanies, life-changing moments, and the heartbreaks. With this series, we have some learning objectives. We hope that the learner will gain a foundational information on pathways into global health and will be challenged to deepen knowledge on equality and mutualism, which garners true collaboration and global health exchange for everyone's equal benefit. We also hope that the learner will examine existing attitudes around global health so that we at the University of Kansas Medical Center are trendsetters who move beyond the us versus them and have versus have-nots mentality. And lastly, we hope that the learner will be able to appraise global health, including global health research, philosophy, approaches, attitudes, and the varied efforts in the areas of health disparities, health inequalities, and community health. We have several upcoming events in this series. We're super excited that Dr. Mani is joining us today. On April 15th, we will have Dr. Anthony Kovac, who's also on the call today, but he will present on international exchange between Peru, Ghana, and the US. On May 4th, we will have Dr. Julian Franco, who will give us a presentation called Introduction to the School of Medicine at the Universidad, and I'm going to butcher this, please forgive me, the Antioquia. I hope that was pronounced correctly. If not, I'm sorry. Or health public policies and the use of frameworks to help the decision makers. In addition to that, we have Dr. Nicholas Communelis, who will present on May 12th on post-COVID global health. Next slide. And with that, I will virtually hand over the microphone to Kimberly Connolly.
Good morning, or actually we're at afternoon. Good afternoon and welcome to our Foundations of Global Health. It's my honor to introduce our speaker, Dr. Mani Mani. Dr. Mani Mani, he's medical doctor's professor emeritus at the KU Department of Plastic Surgery. He was born in India and graduated from Christian Medical College in Vellore in 1961 and completed general surgery training there in 1964. While training under the renowned Paul Wilson Brand, MD, he crossed paths with David Robinson, Dr. David Robinson. The relationship led to an invitation to visit KU Medical Center in 1969 for plastic surgery training and decades of partnership and innovation. Upon completing his residency, Dr. Mani returned to India, and in 1972, Dr. Robinson visited Dr. Mani and asked him to join the faculty at KU. After moving his family to Kansas in 1974, Dr. Mani was selected the medical director of the Jean and Barbara Burnett Burn Center. The protocols for contemporary burn care he developed at the Burn Center was ultimately adopted as the standard of care by every city, hospital, ambulance, and fire department in the state of Kansas. It then became the standard of care in many parts of the US and abroad, including Malaysia, Australia, Kyrgyzstan, and India. Although Dr. Mani officially retired in 1999, he remains active on campus, including as a regular lecturer and with his involvement in telemedicine initiatives in the Department of Plastic Surgery and residents around the world. but he also stays highly involved and collaborative with the Office of International Programs. Dr. Amani is my dear friend and mentor, and I had the pleasure of meeting him when I interviewed for my job. From that day until today, he continues to mentor me, discuss international exchange, and encourage the right attitudes of international educational exchange. Dr. Amani has mentored hundreds of students who've undertaken international educational experiences. For 10 years, we've been sending students to Christian Medical College in Vellore, India. But he doesn't limit his generosity of time and expertise just to those who are going to India. Dr. Mani is willing to talk to anybody, anytime about international exchange. And he is deeply committed to making sure that the individual who is wanting to go abroad and meet others is doing so with the right attitudes. So with no further ado, I would like to hand the mic virtually over to my dear friend, Dr. Mani.
Hi, I'm Mani, and thank you, Kimberly and Christine, for the introduction. My concept today is to talk about global health, and I would like to challenge you by saying, when you talk about global health, is it to serve or to learn, and who is actually being served? Next. All right, global health is a buzzword today. So everyone talks about mission trips. So what is your understanding if someone asks you to go on a mission trip? What do you hope to achieve? And when I got involved with global health about 30, 40 years ago, it was a concept of collecting supplies, Band-Aids, vitamin C, aspirin, Tylenol, pack up the whole bag, go 8,000 miles someplace, and spend a week there and come back feeling good. So now you are there, and the first person that is brought to you is this individual. Next. All right, this is the patient that's brought to you. You're sitting there with all your supplies, and here comes this patient, and you panic. You say, what do I do next? And being trained in the United States with appearance and cosmesis as our primary goal, you'd say, let's call plastics in. Let's call plastics in. This lady needs help. But I tell you, you failed in your assessment because you failed to ask one key question. You failed to ask the patient, why are you here? You assumed that she was here to have those tumors removed. But is it? Would you stop and ask her, lady, why are you here? What is your chief complaint? And then you're not being culturally sensitized. She looks at you and points to her husband and say, ask him. And you're saying, lady, why can't you answer my question directly? But that's not culturally appropriate. She has to have her husband ask the question. So you turn to him and say, why are you here? And he says, two things have happened recently. She's lived with this deformity all her life. She's married, she's got children, she's part of the community, she's part of the village. But of recent months, she is having convulsions. She's having seizures. And she's become totally deaf on the left side of her body. Wow, that changes the picture completely, doesn't it? So can any of you diagnose what this lady has just by looking at her? All right, in the old days, I would say go to the library and look up the books. Today, I'd say go to Google and ask Dr. Google, what is the diagnosis? It is one Recklinghausen's disease of nerves or multiple neurofibromatosis. So can you put the whole picture together? Her facial appearance, her deafness and convulsions. She has an intracranial tumor. That's what she is here to see you for, not the appearance of her face. All right, you say, all right, let me get a CT scan. Let's get an MRI done. The nearest MRI machine is 1,000 miles away. Even if you send the person there and get a diagnosis, what the heck are you going to do? So this is your first patient on your mission trip. Next slide. So this is an older slide. It's about 8 years old. Where does the United States stand in overall planning of healthcare worldwide? They've taken all these countries, which are first world countries, Australia, Canada, France, Germany, Netherlands, and look where we are. We are number 11 in every category except the cost. So America today has the most technologically advanced medical system in the world, most expensive, but when it comes to quality of care, efficiency, equity, healthy lives, we are number 11 in the list. So as you go on in medicine, ask yourself, where am I today? Is this what I'm going to take across the world and say global health, follow me, follow my lead? Is that what you want to happen? Next slide. Okay, let me present to you a very hypothetical story. I created this story out of the air just to make a point. So you open the newspaper and that flashed on the front page is the story. A good group of people from Cuba heard that healthcare in Kansas is very dysfunctional. It is very difficult to get appointments. You call and you make an appointment 2 months from now. Medicines are frightfully expensive. People are using emergency rooms as primary care centers. They have also read, these lovely Cuban people have read, that thousands of children go to bed hungry. So, next slide. So they have decided on a mission trip to Kansas to help out for a week. They have prepared with free medicines, supplies, bandages, lots of food. The Boeing 747 that they have chartered has an X-ray machine, an EKG, and a clinical lab. They will be in town for a week, and they want to tell you that this is a totally free service for anyone and everyone. Now, how would you respond to this idea? You are there trying to do the same thing. When the Cubans come here, what do you think about this idea? Next slide. So who are the people that you hope to serve? Are they in some remote or exotic location, or are they in your backyard? You are happy to travel 8,000 miles at frightful expense to serve somebody there when you're ignoring your own backyard. So are they different from us in language, culture, religion, tradition, and expectation? How are they different? Next slide. So what gives me the credibility to stand in front of you and say these things? I straddle two cultures. I straddle the Asian culture and the Western culture. I straddle the first world and the emerging world. And most importantly, I can think in more than one language, and I can blend in both cultures equally well. Next slide. So are we looking at only at the economic status when we lump them as international? Do we judge them by what we have and what they don't have? Or are we looking at the whole issue from a wrong perspective? I propose to you that we are looking at it from a wrong perspective. So let me tell you my story. Next slide. So can I walk into your home and tell you how to live, how to solve your problems, how to raise your children, how to eat, what to eat, how to dress, what to believe, however poor or forgotten you may be. Why should you, as one of them, trust my motives? Is that what you're doing when you are at a global location? Next slide. So words have been interpreted by hearer in many ways. I would tell you that the last best word in dealing with someone in a different culture, different country, and different faith tradition, I believe the best last word is respect. If you have respect, you will do well. Next slide. So speaking as one from a different culture, and since I come from two different cultures, what does the poor and the forgotten of the world learn about us and our motives by watching us and our action? Sam Harris in his book says, you need not be a faith-based organization to build houses, feed the hungry, and heal the sick. Next slide. So Mahatma Gandhi wrote about social sins. He said, commerce without morality, politics without principles, wealth without work, pleasure without conscience, education without character, science without humanity, and worship without sacrifice. Next slide. So what is their perception from their side? All right, we bomb a village, killing family and claiming collateral damage. They look at us, the first world, living in luxury in a society that subscribes to prosperity theology. Do we really mean when we say, give us this day our daily bread, when the pantry is filled with food and the grocery store is open 24/7 and they even accept credit cards all the time? Now, the next slide gives you a totally different picture. This is a Pulitzer Prize winning photograph taken by a South African photographer called Kevin Carter. Kevin Carter was part of the United Nations team that was helping during a famine in South Sudan. Mr. Carter was the official photographer, and they landed at an aid station, and he was asked to go around and take some good pictures that will impress the world with the seriousness of the famine in South Sudan. So Mr. Carter, walking along, saw this child. The gender of the child is still undetermined, crawling towards an aid station. And as he was focusing his camera, a vulture landed behind the child. He shooed the vulture away and got the camera focused again and got this picture, which won the Pulitzer Prize. At that time, Mr. Carter was called by the team to rejoin the flight. They were going to the next aid station. So he left, got into the plane, and went away. He did not pick up this child and take the child to the aid station, and he does not know the fate of that child. No one knows what happened to that child. Kevin Carter could not live with his decision, and in 3 months' time, he committed suicide. Is that what you want to do? Give us the day our daily bread? Next slide. So we can serve them and partner with internationals in several situations. We can partner with them in time of disaster. We can partner with them in times of war. We can partner with them in times of peace, or are part of a long-term strategy. But what are your motives in getting involved in international and global situations? Next slide. So I show you this picture, and this is in the hometown that I grew up in India. They had 40 inches of rain in 1 week, and all the streets got flooded. You can see the picture of a car floating in the flooded streets. And you would say, all right, let's go, let's load up and go help them and take a set of supplies, bail them out because they have this flooded situation. Next slide. But where are you going to land? That's the airport in that town. You see all the planes standing in about 4 feet of water. So where are your motors? How are you going to get there? How are you going to serve these people with your 747? This is where the locals have to step in and do what they have to do. Next slide. So again, I ask you, what gives me the credibility to stand before you to say these things? What has been our experience? Our team at KUMC has set up programs and dialogue with people in Kansas, in India, Malaysia, Kyrgyzstan, and Australia in the field of plastic surgery and burn and wound management. Remember, 1969, I was a stranger in this country. I was an unknown. I was a brown-skinned person from another country. In 1969, there were 4 of us who were from outside the United States. 1 from Ethiopia, 1 from Australia, 1 from Thailand, and me from India. We were known as the damn foreigners. That was our name at that time, 69. From 69 to now, how far have we come? Next slide. So our team organized a system of burn management for the entire state of Kansas. This effort was from 1975 to 1985. And I was a stranger and unknown at that time. Can you believe that in 1974, we did not have an emergency medical service system? I was part of the group that started EMS in Kansas. We had no 911. We had no paramedics or EMTs at that time. We had no organized ambulance service. We had no air transportation. So this is where we started. And look where we are now. We are absolutely top of the world. And I'm so proud to be having part of that service. Next slide. So what we did was we wrote a protocol, care of the terminally injured patient. And I want you to listen to me. I have visited every hospital in the state of Kansas that has a medical system. Primary care, secondary care, tertiary care. And this is what we pasted in all the emergency rooms to follow a protocol when somebody with a burn injury came to them. It took us 10 years to teach the entire state of Kansas. And I have visited, like I said, every town in the state of Kansas. Next slide. Then we took the program to Malaysia, to Kyrgyzstan, Australia, and to India. When Dr. Robinson hired me in 1974, he gave me 3 charges. One was to organize burn care in the KU Medical Center. 2 was to organize burn throughout the state of Kansas. And then he said, take the Jayhawk to as many countries as you can. And we did. Next slide. So it was truly a learning experience. Each region needed a totally different approach. My approach from India to Kansas was different. From here to Malaysia was different. Every country we went, we had to reorganize our thinking. The core knowledge remained unchanged. The vision remained unchanged. But the way we approached the local partners and national leaders was quite different. Next slide. So I'm going to take you through my life journey. I'm 84 years young, and I've been to many countries. So the first adventure after Kansas, because India, Kansas, was Malaysia. How many of you have been to Malaysia? You may have heard about Singapore. Malaysia is a country separated by the South China Sea, and it is in two separate areas, Peninsula Malaysia and Sabah, Sarawak. I can tell you, I have visited every town in that country that has a hospital. It was a 10-year effort. Next slide. So I had the unique opportunity to get involved in Malaysia. The chief of plastic surgery in Kuala Lumpur, which is the capital city of Malaysia, was a former student of mine. I was visiting him on a social visit in 1984. I was on my way from India to the United States, and I routed my trip through Malaysia, and I visited my friend in Kuala Lumpur. And there I was introduced to this young girl. Next slide. So this is the girl that I was introduced to. We went on rounds, and this girl was there lying in a hospital bed. And there was a small party going around her bed, because they were celebrating 1 year of her stay in the hospital. She had spent 1 year in the hospital with burn of both legs. And as you look at it, it is not completely healed. She's not ready to go back home yet. There are still open areas. So we did rounds, and when we came back, I asked my friend, why is this patient here for 1 year? I thought I taught you differently. And he said, sir, that is our system. Next slide. So I said, let's change the system. Let's change it completely. So he and I should say, over many cups of coffee, it was beer, made a decision as to what we should do. And we decided at that time that we would take on the entire country of Malaysia, not just one town, not just one hospital, the entire country. So we made an assessment of the healthcare system of Malaysia. I took my sabbatical, and I spent 6 months in Malaysia, and I visited every hospital in that country. We looked at the health hierarchy, health directorate, hospital facilities. We looked at all the equipment that they had, all the supplies they had, the faculty, the staff, the training, the educational resources, caseload, and we wrote a report and submitted to the government of Malaysia. A copy of that is still in the Clendening Archives Library. That was 867 pages long. We submitted that to the government and convinced them that we could make a change and set the whole thing up for the country of Malaysia. Next slide. And interestingly, I met a lot of different people. Malaysia is a different country with Muslims, Chinese, Indian, Eurasians. They form the whole spectrum. So we made friends with every one of them, and we taught them, we trained them. Next slide. And we trained not only physicians, but nurses, physical therapists, occupational therapists, dietitians, the whole spectrum, the team that was there necessary to take care of patients with burns. Next slide. And there were several different levels of hospitals. This is a primary care hospital where there is maybe a physician, a surgeon, an obstetrician, and a pediatrician. And we decided this is not a place to take care of patients with major injuries. Next slide. And then they had big hospitals. They had hospitals with every equipment and facility you could think of. So we decided that the primary health center, primary care center would just be a receiving center, do primary assessment, and then transport the patient to the bigger centers. And we set up the units in these hospitals. Next slide. So I spent 6 months, my sabbatical leave from KU. I submitted a budget for $40,000 to be raised locally. We decided very early on no funds from the United States, period. All the funds would be local, and the oil company, SO Malaysia, gave us $30,000, and the Malaysian gave the rest. And we trained the first batch of 400 medical, nursing, and allied professionals in 1986. So we were dreaming big, and we achieved it. Next one. Next. So in those era, deformities was accepted as normal. Let the patient heal with deformity, and we can fix it later. We completely changed that concept. We should never allow a person to go to this kind of deformity. We'll catch it long before, right from word go, and then go on to what is accepted in the first world practice. Next one. And then we wrote a book. We wrote a book on burn care and rehabilitation. We printed out 500 copies, distributed to all the participants. So now the country of Malaysia has one standard of care for the entire nation. So if you want to get involved, dream big, think big, act big. Next slide. So over the 10 years, we trained the trainers. We trained physicians, nurses, and all the occupational, physical therapists, firefighters, ambulances. We trained them for 10 years. We would go there once, twice a year. The funding for us, I provided from Kansas, but all the rest happened in Malaysia. And from 1986 to 96, we trained them. And in 1996, they took over. At the annual meeting of the Malaysian Association, the head of the plastic surgery burn team said, "You have taught us well, you don't need to come back." So we were fired. We were fired from our job. That was the greatest day in my life. Yeah, next one. So what did we achieve in Malaysia? In 1996, we established 8 centers for plastic surgery and burn surgery. We trained over 400 professionals. We used the existing facilities and equipment locally. We did not take anything from here. Everything was developed locally. Now, the locals are carrying on the program, and in the process, we made a lot of friends. Even today, I get emails from friends in Malaysia. Next slide. A few months later, after we ended the training program, I got a call from the government of Malaysia asking, can we train our people here for microsurgery and transplantation? So we got 4 people from Malaysia come, spend time in Kansas. We trained them in microsurgery and transplantation. They went back and they're doing it now. They don't need us. We provided the training and they're doing it on their own. Next slide. The next adventure was to Kyrgyzstan, which is a Central Asian republic. There is Pakistan, Afghanistan, Tajikistan. On top of that is Kyrgyzstan. And on the east side is China. And the north of that is Kazakhstan. We had the opportunity to go to Kyrgyzstan to set up the program. Again, we took on the entire country. There are 2 major towns, Bishkek and Osh, and those are the 2 major hospital centers in Kyrgyzstan. And we were asked to set up the program, and which we did from 96 to 99. Next slide. So we had the opportunity to get involved in the Central Asian Republic. It is a program through the American International Health Alliance, an arm of the State Department. We were asked to go there and upgrade the system for burn care. That was our charge. Next slide. But there was a huge obstacle. There was a huge obstacle between working in India, Kansas, and Malaysia. These places had a common language, English. In Kyrgyzstan, they spoke Russian, and we did not speak a word of Russian. So we had to have a translator at every step of the way. And this was soon after the Soviet Union and America made peace, and they did not trust our motives. The Russians were telling us, yeah, you were here last week trying to bomb us, and today you want to come and teach us? What is your motive? The next one, we were sent by AAIHA and not invited by the locals. We had to win their trust. They did not trust us. India, Kansas, Malaysia, they trusted us. Here they did not. The Russian system was quite rigid, and you only do what Moscow tells you to do. Country was economically poor, and health system left a lot to be desired. So that was the change between the previous three countries and Kyrgyzstan. Next one. And they were really poor. If you look at it, I'm wearing a mask, and they wanted me to wear the same mask for the next 2 weeks. I threw it away at the end of the day, and they said, where's your mask? I threw it away. They said, oh, that was your mask for the whole week. And if you look at it, we don't have gloves. We are wearing plastic gloves, no bandages. Next slide. I don't know if you can see this picture. This physician has got a dirty bandage on his white coat. He's got no gloves on. He's cutting the bandage open. And for them, it was normal. It was their standard. It was what they used to. We are appalled at what they are doing. We had to change their system. But how do we get them to do that? Next slide. So their primary goal was hospitality. They just wanted to treat us well. And we were surprised that for lunch, they had vodka for lunch in the dining room. And they wanted us to drink. We had very limited time to make the assessment, but they kept us drunk all the time. Parties will go till 9, 10 at night, and they would pour vodka and champagne. That was their goal. We were not there to drink vodka. We could have had that at home, but that was their goal. We had to fight that system. Next slide. And every day there was a party. There was food, food, food. That was their interest. They were going to treat us nice. They were really not interested in learning what we had to teach them. Next slide. Okay, culturally, can you see that picture? That piece of meat was served on my table. And if you look at the right side of that picture, the piece of meat, you can identify the head of the femur. And if you look at the left side, you can see the bottom of the femur. The entire piece of meat between the head of the femur and the thing was served on my plate. Now, socially, you have to be trained to deal with this situation. Our immediate reaction was, no, I can't eat all that much. Culturally, it would have been a slap in the face for them. But I was prepared. I was trained by a local Russian on how to behave. What you do is you accept that thing gracefully. Thank you very much for your hospitality. Then you ask for a knife and a fork, and you cut it up into small pieces and distribute to everybody on the table. Culturally, that was the right thing to do. And because I was trained in cultural, I did not break protocol. I asked for a knife, I cut it up into pieces, passed it to everybody, kept a little piece for myself, everything went well. That's how you win friends, by knowing cultural behavior. Next slide. So we had to break the stalemate. So finally we appealed to the Prime Minister of Kyrgyzstan and saying, please, please, please don't have us drink this much of alcohol as we go along. So he was very supportive of us, and he gave us, we said, give us 2 patients, give us 2 of your patients, we'll treat them our way, and then you can decide whether our way is better or your way is better. Next slide. So they gave us 2 patients. This gentleman had been in the hospital for about 8 months, not ready to go home. So my therapist, my nurse, and I, we went to town, we went to the market, we got bandages and gauze and clean stuff and all the rest of it, wrapped him up, got him up walking, and in 3 days, the guy was ready to go home. That broke the ice. Once we broke the ice, we could not do anything wrong. Next slide. So here we are, working with the patient, making them walk, making them think, and they're smiling and they're ready to go home. And from then on, we could not make any mistakes. So it was wonderful that we were able to get through to them and say, look at our system. Our system has got a few benefits. Take it and leave it. Okay, next slide. So once we got their trust, we could do nothing wrong. And we went back for training sessions in 2 major centers. We trained doctors, nurses. The Soviet system did not have allied health PTs and OTs. So we had to create a new cadre for them, and it worked well. So they're still continuing to do what they do. I get emails from them once a month. They're doing well, and we are happy for them. So they're on their own. Next slide. They had very little bandages. They had very little splints. So we had to use plaster of Paris to do all of that. Next slide. So improvise every step of the way, every step, bandages, splints, operating equipment, supply, everything. And 10 years later, they were able to find what they want from their own resources. They are not dependent on us. That's the beauty, what I want to tell you. If you're going to train them, let them find their own resources. Next slide. Mrs. Redford was our coordinator, and she was a fascinating lady. She was born in the Ukraine, so she's fluent in German, English, and Russian. And she was the one that guided us with all the cultural activities. So get somebody like Mrs. Redford who can lead you, who can guide you as you go into a new culture that you're not familiar with. Once you get the hang of it, it's easy. Next slide. The book that we wrote for Malaysia, we updated it, and Mrs. Redford translated the entire book into Russian. So each participant in that country has now a copy of our book in Russian, not in English, but in Russian, so they can read. So these are the things that you need to do as you go along. Next slide. This was their standard of care. If this patient survived, they felt good. We felt horrible. We said, this is not the accepted norm. So we went step by step, walked them through and taught them, and now they're on their own. They're doing very, very well. They don't need us. Next slide. So India was a totally different system, well-trained healthcare professionals. It is British system of training. Most burns are in government hospital. So we were able to get through to them, and language was not a problem. And we gave priority to those who had chances of meaningful survival. Next one. So the next step was telemedicine, and telemedicine is freely available. And now with all the electronics, it's so easy to teach, sitting here and learning from them and teaching them. So it is a two-way street, and we are happy that we have a good program going between Kansas City and India. Next slide. Then I got a chance to go to Australia. My wife and I went to Australia 6 years in a row. I was invited as a keynote speaker, and during that time, they wanted to do what we call ATLS, ACLS, ABLS, and they wanted my help. So I was there 6 years in a row. We trained them, we taught them, and they're on their own. And the system we set up for them now is used in the Philippines, is used in Singapore, is used in Malaysia, and is used in the UK. So you have the opportunity to be able to be helpful in many, many parts of the world. Next one. Next slide. So if you hope to make a difference, you need to understand the language, the culture, the tradition, the religion, and why they do what they do. And don't forget, imperialism has been with us for the last 300 years, and the effects of the various empires are still very, very sore points when you go into third world countries. Britain, Germany, Belgium, all those countries had colonies all over the world, and they are sore points. So the key to open doors is respect. That's what you need to do if you want to make a change in what you do. Next slide. So here is a poem that I would leave with you. This is from Lao Tzu in China and translated into English. It says, go to the people, live among them, learn from them, love them. Start with what they know, build on what they have, but of the best leaders, when the task is accomplished, the people will remark, we've done it ourselves. So credit goes to them, not to you. Next slide. How many of you have heard of the headhunters of Borneo? These are headhunters in the island of Borneo, and they will kill and behead the head and shrink it. So they are called the headhunters of Borneo. I had lunch with this man, and if you look at his neck, he's got a tattoo in the front of the neck, which means he has beheaded somebody in combat. So you can meet them. He's a friend of mine. I've had dinner with him. Why not? This is the beauty of global health. Next slide. So here is a word from Lila Watson, an indigenous Australian in Queensland. If you have come here to help me, you are wasting your time. But if you have come because your liberation is bound up with mine, then let us work together. I'll stop there and say the traditional Indian greeting, namaste, which means I recognize the divinity within you and I respect you for that. So I'm open for questions. If you have any comments, questions, disagreements, I'm here.
Dr. Mani, beautiful presentation as always. You speak from the heart, you speak truth, your message is eternal. It won't change because it's truth. Whether we're in 1960, 2030, doesn't matter. It's a message of truth. I especially like the last quote that said, if your liberation is bound up with mine, then let's work together. That's just it's beautiful, really beautiful. I was curious, you have
let me interrupt one word and say, it is so much fun. It is so much fun to make friends. I can go any part of the world and have somebody meet me. I can go to China, I can go to Hong Kong, I can eat Malaysia, I can go anywhere, and I got friends there. And I get hundreds and hundreds of emails every day. It is so much fun. So at age 84, I'm saying have fun.
Well, and that's a really good point, because friendship is built on mutual trust, understanding, and collaboration. That's what friendship means. And so if the pursuit is friendships, it's going to be productive. If the pursuit is helping, saving, it's not going to be as productive because it's hierarchical by definition.
Yes.
So friendship should be the goal. What questions do we have? Priya, I see you there. Hello.
Hi, ma'am. Hello, Dr. Mani.
Oh,
Sir,
hi.
that was wonderful. Hi, sir. It's a great honor to be in your presentation, and it was really, really wonderful and very heart-touching. Thank you for sharing all your experiences. It was awesome. Thank you. I just love the Kyrgyzstan place where you made such a big transformation in the lives of people in treating and learning from you all. Thank you so much, sir. Thank you for sharing. It was wonderful.
Good.
Deb, did you want to say something? I saw you turn, no.
I just turned it on.
Okay.
But I will say it was phenomenal. I really appreciate it. So thank you, Dr. Mani.
Dr. Mani, did you have, I know you had many experiences and many things that impacted you in your life, but was there a moment, like a momentous interaction that really helped you understand kind of your, almost like your philosophy or your destiny relative to global health and international educational exchange?
I think is to listen to the other side, listen to the other side. Somehow we all feel my way is the best way. Not necessarily so. If you look at their system, how do they handle it under their conditions? How do we handle it under our conditions? Conditions are so different. So if you listen to them, you learn much, much more, which now you can adapt to your system. That's what I want. Listen, listen, listen.
I have a question. So,
Hi, Tony.
hi, it's good to see you. You know, one thing, I'm just in the last 5 years getting into the international visiting and going to Peru and Ghana. And I tell, and even around the medical center and my department, I'll tell them I'm going there. And it seems like the first thing they always say, oh, you're going on a mission. And I say, well, no, I'm not going on a medical mission. Actually, I've never been on a medical mission. This is a medical education mission or learning. And I guess my question is, I mean, I think that your presentation like today is a way to educate us in the approach, the best approach. But how do we get people in the US and the state, in our own university and departments to change their thinking from the medical mission to the medical education, or that actually we're going over there to learn from them? I guess
Tony, I would say this. Show them the first picture that I showed of the lady with the multiple neurofibromatosis and say, all right, fix it. And then suddenly you find that you're wetting your pants. You have no idea what to do next. How do you manage anesthesia with a person with this kind of a tumor? How do you intubate them? And what happens to the brain tumor? So once you are challenging them with these kind of cases, and I've got tons and tons of photographs of terrible, terrible deformities that I show them. Alexa, if you have the next picture on the screen that I have, if you can project that,
You would have to share
that and say, all right, what do you do next with this? And then suddenly you realize that your armamentarium is not good enough for, so you show them actual clinical situations. It's not a question of putting a Band-Aid. It's not a question of giving them Tylenol and say, come and see me tomorrow. No. How do you help them fix it? That's what we need to show them cases. And I challenge the plastic surgery residents. I've got pictures that make them gag. All right, what do you do with that child? That child was presented to me. What is the diagnosis? It's a symbiotic infection of anaerobic and aerobic infection called noma, cancromatus. The entire lower jaw is gone. The mandible is gone. What do you do? Little child, about 3 or 4 years old. What do you do with that child? Confront them. All right, here is the patient. How are you going to fix it? Next slide. So we treated the child conservatively. We were able to preserve part of the mandible, and that she is about 6 months later. Next picture. All right, that's the end result. Challenge your students with that. Come on, how are you going to fix that child? Then suddenly you wake up to realize it can be done if you are properly trained. That's how I would do, Tony. So I would collect a whole bunch of these lovely photographs that make you gag and ask your fellows and residents and students, saying, what do you do with this? What do you do next? That'll wake them up. A Band-Aid won't fix this child. Going on a mission trip is not going to fix this child. You need to have somebody well-trained to take these on and fix them long-term. So you trained the local person who can do these when you are not there. You can't be there all the time. Unless you want to relocate to Peru and live there for the rest of your life, fine, wonderful, I bless you. But if you can't do it, you're going there for a week at a time, 2 weeks at a time, train somebody locally to take over. This is one of the patients I operated on.
You know, and I would add to that, Dr. Kovac, to your question, because you know this is something we grapple with, right? You and I, this is the question for the last 8 years. But I think the answer is in Dr. Mani has also created a cohort of faculty and administrators and students who believe this philosophy of learning and educational exchange, and who rejects the colonial approach and colonialism. And so I think that then that's also our task, right? It's our job to repeat these stories, repeat this message, to invite people to these presentations, to share the link, to make sure that in every conversation that we're using the right words and we're promoting these exchanges with the right philosophy. And it's repetitive, and sometimes some days we think we're not ever going to change the attitudes and cultures, but then we do. You know, it's slow and it's tedious, but it's that consistency that creates the right culture. And so having individuals like yourself who, you know, who have listened to Dr. Mani and talked with Dr. Mani and who come from that same perspective, we will recruit more. You know, we will have more and more, and pretty soon we will be more than those who promote medical missions and the medical mission mentality of being superior.
I'll say, as someone who, you know, helps prepare the students for their international experiences, I'm grateful to both of you that they get to hear this perspective that we want them to have about international exchange and education and learning and respect, and that it's not about going there to save somebody or to, you know, be the missionary or anything like that. I love your philosophy, and Dr. Mani, it's always just like so wonderful to get to hear you. So thank you so much for joining us today. I really appreciate it.
I see Deb Sullivan in the group. You know, Rebecca did this also all over the place. She set up the program after Ruth Gordon and Australia, Malaysia, India. Yeah, so anybody can do it. It's not just a physician, a nurse, a PT, a dietitian. Anybody in the field can do it.
Yeah, and that's another beautiful aspect you brought up, was that interdisciplinary team that I don't know that we put enough emphasis on in the US, but you really see it, I think, around the world, where they do have everyone working together on one team.
Yes, it's fun, a lot of fun, a lot of fun.
It's been a labor of love, I know. And that's the other element in this, is friendships and love, and that brings people together. So thank you, Dr. Mani.
Thank you. Thank you for the opportunity.
All right.
Okay,